Welcome to today's talk. We will be discussing ultrasound in trauma, and we'll go from fast and beyond. So, everybody has heard about fast and ultrasound in trauma, but is it all we can do, or is there anything else? What else can we do with ultrasound? Is it a tool? Is it a toy? So, let's discuss a bit about this. Our objectives today are discussing the importance of trauma ultrasound and to revise and discuss a little bit of the normal and the alterations that you can see when scanning the patient. So to start, you have a little case. You are the ER doc. You are the beginning of the morning shift. It's a slow, rainy day. You're drinking your cup of coffee, waiting for the patient start coming. It's so calm until you hear the sirens blazing and the ambulance coming to the ER and the crew shouting, "We need some help here." And you just throw your coffee through the window and rush to the ER. They bring a 23-year-old male after a motorcycle versus truck crash. The patient comes with C-collar and the backboard, and they didn't do any intervention. They just brought the patient to the ER. As it was closed, they thought they wouldn't waste time doing anything else, just brought in. So, what do you do now? Where do you start with this patient? Should we start with CAB like ACLS? Should we do ABCDE like ATLS? Or should we go XABCDE like PHTLS? Or just call SOS and leave the room? What should we do? I tend to think that we always should start with X. Okay, PHTLS is for pre-hospital, ATLS for intra-hospital, but for me it makes more sense that if you have eXsanguination, that should be your priority. Even if the ambulance crew has already stopped the bleeding, they put a tourniquet on or something, you should check it again when you receive this patient in your bay, because it may have dislodged or anything. So just start with X, but this patient has no external bleeding. You breathe calmly and proceed with the evaluation. When checking the airway of the patient, you see a bad facial trauma with a lot of blood in his mouth, blood oozing. The patient is not breathing easily, he's gurgling, and you just think, well, I have to intubate this patient. We have to secure this airway. So you get your blade, your tube, you get in, and you think, okay, I think it's in. Now what? Is it in the right place? How do I check it? Well, the gold standard is having your capno and see the wave. You know, this takes a little bit of time. And as this is an ultrasound class, is there a place for ultrasound here? Checking where the tube is? Yes, there is. A couple of recent studies have seen that using a probe to check the position of the tube is pretty much as good as capno. So it's still not the gold standard, but it's pretty much close, and it's quick and it's easy, and we can do it. What are we looking at? You're going to check for, you put the probe, preferentially a linear probe that you can have a good visualization with low depth. So we have high frequency probes. You are going to come from the sternal notch, put the probe, and try to see this. This is the bullet site. You know, everything in radiology, they tend to see things because they're very creative, and I think the radiologists get a bit lonely in their dark corners, so they tend to see a lot of things in these images, but they see a bullet here. So we see this black sphere, that is the trachea. We know that the air is not a very good conductor for sound. That means we have this image and sound doesn't go very well past it. So we have a shadow behind it doing this sign. These reverberation artifacts tend to indicate that the tube is in the right place, especially if you're doing it dynamically. You move a little bit the tube and you see these artifacts moving with it. It's a very good sign. And when we are looking at it, we don't see the esophagus. It's a virtual cavity. It's always one wall sticking with the other, and just when you are swallowing something, it will pass, but the walls are always touching themselves, so we don't see air in it when we are probing it. So that's the image we want to see. This is the a little video, but the same thing. We see just one image. Here we have the trachea and a shadow behind it. Here we are seeing something else. We have our trachea, we have shadow behind it, and we have a little black dot beside it. That shouldn't be here. We have air and we have shadow after, behind it, so we have the tube in the wrong place. So this sign means we have air in the esophagus and it's the tube in the wrong place. So this is we see the two spheres, meaning we have air in two different places, and it's not what we want to see in this moment. This is the double track sign. It means you don't have to wait for capno or anything else. You just take the tube out and try it again because it's in the wrong place. Okay, but we didn't see that. We saw that it was in the right place. You breathe easily, airway secure. Now what? What's the next step? We have X, A, now we go for B, breathing. You check the thorax of the patient and you see a bad bruising in the thoraco-abdominal region in the left side. The patient, before the intubation, he had a very fast respiratory rate. He was asymmetric, in very much discomfort. You know, it's not good. What are the wounds that we are thinking? Pretty much when we think about thoracic trauma, we will think about pneumothorax, hemothorax, or pulmonary contusion. It's pretty much the three main lesions we can see in this patient. And how do we diagnosticate? How we make the diagnose? Well, usually we would get our stethoscope, try to listen for the lung sounds. If they are asymmetric, you might go for percussion, but we know that this is not the most straightforward thing, especially when you are out of the hospital or in a busy ER with a lot of people, a lot of noise. It may get a little bit difficult to get a very good physical exam. So the solution for this is the ultrasound, obviously. We are going to use the eFast, or the fast protocol extended with the blue protocol. So we will have these extra points to probe, at least these main 6 points, sometimes 8, sometimes you just probe the thorax all along. So the minimum is 6 points at least. And what do we want to see? This is a normal lung. If in the one hand air doesn't conduct sound very well, on the other hand, solids like bones, they just sound can't pass it. It just comes back to the probe. So it won't pass through the bone. So we have also shadows behind the ribs. So what we are looking is the probe is between two ribs. They have their shadows. Here we have the subcutaneous tissue, and this white line here is the pleura. We can't see the pulmonary parenchyma due the air is not a very good conductor, as we talked about, but it has some artifacts. Mainly what we can talk here is the A lines, these reverberation lines that are equally distant. This means we have parenchyma, usually healthy parenchyma, uh, underneath the probe. So this is what we usually would see on a static image. On a dynamic image, what we are trying to see is here we have the ribs, the subcutaneous, the pleural line, and we have two pleuras, and they tend to go one over the other so the lung can move. So what we want to see is these little artifacts, or sometimes we can see it sliding. So it's the lung sliding. It's what we want to see. This means we have a healthy pleura. And in here we have the two modes, the B and M mode. So here the image we were talking about, the A lines, subcutaneous, the ribs, and here on this image we have pretty much the same thing, but in a more over 2D, but this is a different view. Here we have the subcutaneous, the pleural line, and the parenchyma. Again, the radiologists in their basement, they were thinking about vacations and they wanted to go for a resort or something, I guess. And they saw a beach here. So if you come with me and trust me, this is the sea. This is where the waves are breaking, and here is the sand. So beaches are good places. The seashore sign is a good sign. Means a normal lung. And here what we have is we have the ribs and the pleura, and here we see some moving, and here's it's still. So this is the lung point. This means I have healthy pleura here, one sliding over the other, and here we don't have the sliding. In this case, we are talking about trauma. This means we have a pneumothorax. It means we lost the contact of the two pleuras. So, to sum up, we have the seashore sign, that's normal. If we have no lung sliding, we can see the barcode or stratosphere sign. So it's pretty much all the same image. Instead of having the beach, we have a stratosphere or a barcode, and this means we can't see the healthy lung beneath it. So we have this artifact, meaning we have a pneumothorax. And if we are lucky, the patient's not lucky, but we are, we can see this image, the lung point. So we have the seashore in one side and the stratosphere in the other side. This means that we have a healthy lung here and we have air here. So this is exactly where the pleura is disconnecting from the other. This may help us estimating a little bit the size of the pneumothorax, but it's not very precise, but we can have some idea. Also, we may see this. Here we are seeing the liver, the diaphragm, and here we have the lung collapsed. And all this black stuff is free fluid. So in this case, we have a trauma patient. This means it's blood. So we have hemothorax. We wouldn't see this, we wouldn't see the lung usually, but as it's collapsed. Now we don't have air inside the alveoli, and we can see the lung floating in this free fluid. Some people think looks like a jellyfish. This, I guess, looks a little bit more like a jellyfish. So this is the same image, the jellyfish sign, meaning we have free fluid and a collapsed lung here. Also, we can see these little white sparks. This talks more to us, meaning probably this is blood. Sometimes these are clots, so not very, the liquid here is not as homogeneous as before, but in this case we have blood, we have hemothorax. But in this our patient, we saw signs of pneumothorax. We had a shocked patient. We decided to do a needle decompression. After hearing the air pop, the patient is a bit better. His breathing is better. His expansion now is good. So we have the B fixed. Breathing is okay. So XAB. Next step, circulation. When we're thinking about circulation, we think about pumps and pipes. So we'll see how are the pulses. Peripheral pulses are fast and weak. The skin is pale, wet, cold, and capillary refill time is over 6 seconds. This is not very good for our patient. This means we have shock. And what is the main cause of shock in a trauma patient? It's hypovolemia. It's loss of blood. What's the second cause? Hypovolemia. The third cause, hypovolemia. So if we are thinking about shock in a trauma patient, we have to find out where he's bleeding out from. We already seen that he has no major bleeding outside. His lungs, he had a pneumothorax but no hemothorax. So now we have to see where from is this blood. What's causing this shock? We're gonna check his heart firstly, and then his belly. This is a subxiphoid view. We are seeing the liver and the heart. This is a very good window for us to see if there is any sign of cardiac tamponade. So here we can see a healthy heart, no free fluid over it. This is what we are hoping to see. Sometimes this view is a bit challenging, especially depending on the patient. When he's prone, it's a little bit hard to get a very good view, at least for me. We can try to get the apical 4-chamber view. So we will try to find the ictus where the heart is beating, the little bit of the tip of the heart, and probe it. And we try to see also this image where we can see the 4 chambers of the heart. And also we hope to see no free fluid around it. What we don't expect to see, or at least what we don't hope to see, is this. The heart not pumping very well, a little bit lazy, not very good, and a lot of free fluid around it. Also, we can see alternating polarities on the ECG. So this is a cardiac tamponade. Here we see the same image, but in this one, this is not a trauma patient. The heart seems to be a little bit better, but yeah. Here we see the free fluid, and this is cardiac tamponade. Of course, if we have the setting of the trauma patient, this means that this is blood. So In our patient, we didn't see any pericardial effusion. We still looking for where is this his hypovolemia, his shock is coming from. So it's not from the heart. We're going to check the other windows from the fast exam. So here we have the liver, the kidney, the diaphragm. Here is the lung. We can't see the parenchyma very well, but it would be here. So this is the hepatorenal window. Here we can see the kidney and the liver touching each other very well, no free fluid. That's what we hope to see. Here's a dynamic image of the same window, the, the kidney, the liver, and the diaphragm. On the other hand, we might see this. So we have the kidney, the liver, and free fluid. This black stuff is free fluid. We can't say where it's coming from. We know that it's inside the belly. We can't say this is a renal lesion, a liver lesion, or aortic, or whatever. We just know that there is free fluid, and as we are with a trauma patient, this probably is blood. And here we see the jellyfish sign. No, this is not the jellyfish sign. It looks like it, but it's not. How do I know it? Firstly, because ultrasound is operator dependent. So I am probing the patient. I should know where I am. And especially because I can see very well the kidney. So if I have the kidney, this can't be the lung, right? So this is the liver. And here we have free fluid. So probably blood. On the other side, we are going to check the spleen and the kidney on the splenorenal window. So it's pretty much the same image, but instead of seeing the liver, we're trying to see the spleen, the diaphragm, and the lung. So pretty much a very similar image, the kidney, spleen, and the diaphragm. And here also we see the kidney, and the spleen is taking a dive here in the free fluid. So this probably is blood. And lastly, the window we are going to check is the suprapubic one. Here we see the bladder, as this is a male patient. Underneath it, we may see the prostate. So we are going to check for free fluid, and in this case, we don't see it. In this image, we can see the full bladder, and here we see free fluid outside it. So again, probably blood. This is a window where we can often see the free fluid, because depending on the position of the patient, the blood tends to flow downwards, and this may be a sensitive way to find it. Doesn't mean that this is a lower bleeding. We can't know where it's coming from, but we know there's free fluid. And that's what we see. We see free fluid in this patient. Now what? What can we do? We have to do volume. So we have to fill the tank. There's no argument that the best fluid for this patient is blood. He needs blood. He is losing blood. We need to carry oxygen. We need to have platelets and coagulation factors. So we need MO components. Also, we may use TXA, but this patient needs surgery. So he needs surgery because it doesn't matter how much fluid I give him. If the pipes are leaking, it will keep leaking, and I'll keep giving him fluids, and he will keep leaking until he dies. So we need to fix the leaks. And who does that? The surgery. So if we don't have surgery in our hospital, we're going to transfer this patient. We already start thinking about this, and probably this patient needs to be transferred sooner than later. But we keep checking our patient. Now we go for the disability. The patient was irresponsive upon arrival. We saw a lot of blood on his mouth, our priority was the airway. We decided to go for intubation. We get the ETT in with rapid sequence intubation. Now he is on drips and has bilateral meiosis. How can we check his neurologic status? How can we know if he has a bad TBI or something, if he has brain swelling? Can we see it? It's hard to see now if he has anisocoria or something like that. But again, the answer is ultrasound. We can do the optic nerve sheet examination and measure it. So we get a high frequency probe on the eyeball, and we are going to measure this. So the image we might see is this: the cornea, the iris. We are going to see here the retina and the optic nerve sheet. That's what we are trying to measure. We are going to measure from the retina 3 millimeters, and then we on this height we measure the optic nerve sheet. So here we have the retina 3 millimeters, that's distance number 1, and on this axis we are going to measure the size of the sheet. There's a little bit of argument on the cut points for us to say that the intracerebral pressure is increased, but often we use 0.55 or sometimes 0.6, but this is probably an elevated ICP, and this is for sure an elevated ICP. And as this patient is not a lucky patient, that's exactly what we see. What we do, no, sorry, other than that, what we might see if we have a good enough probe and the patient is having is the papilledema. Here you can see the papillary edema very well. So this is also a sign that might be seen. This also means elevated ICP. We see signs of ICH on the probe, and we start clinical measures. So we try to lower his ICP, and we call neurosurgery. This guy needs to get a CT, need to get evaluation, and may need to go to surgery for that. And we don't have this in our hospital, so we need to transfer him. We call in, and of course, HEMS comes, and the helicopter. I'm joking with the of course because I'm a HEMS doc, so we come, we get the patient, and we in the hospital can breathe again because now it's the HEMS problem, not our problem anymore. We did all we could. The patient is as stable as we can do. Now he needs extra resources, and it's time for his flight go for a trauma center where that can give him all that he needs. If you have any questions, feel free to type on the comments below or just drop me a line on Instagram. Thanks for watching.